So patients that have had surgery in the past, whether it's been a gastric band or a gastric sleeve, and haven't achieved their goal weight, so they might have gone from 120 to 80 kilograms, but really want to be 70 kilograms. Those patients, there are further treatment options, converting the band to a sleeve, converting the sleeve to a gastric bypass, or converting the sleeve to a SADI-S, a duodeno-ileal bypass. I don't recommend further surgery for patients that only have 5 or 10 kilograms to lose. The risk profile for surgery is too high for them to lose 5 or 10 kilograms. So in those patients, we work with them with their diet, we work with them with exercise physiology, and we give them the options of the medications. Some patients are successful in losing that 5 or 10 kilograms with the medications. Others find the side effects of nausea and constipation and vomiting a little bit too much, and then they just stop the medications. But for those patients with a little bit of weight to lose, 5 to 10 kilograms, I do think Ozempic and Wegovy has a role for those patients. And other patients who have 25 or 100 kilograms to lose, surgery is definitely the best option for them. We can simplify surgery into 3 main types: the gastric sleeve, the gastric bypass, and SADI-S. SADI-S is actually a combination of a sleeve and a bypass added together. The sleeve decreases the size of the stomach, so most patients can eat about half a cupful of food after a sleeve. They feel really full up when they eat half a cupful of food, and they can't fit any more food in. So the sleeve increases their GLP-1 to give them the satiety or the full up feeling, similar to Ozempic and Wegovy, although to a much greater degree with the surgery. The second thing the sleeve does is it decreases the production of the hunger hormone called ghrelin. So patients with a sleeve feel full up when they eat small amounts and have decreased hunger and have a decreased capacity to eat. So those patients tend to be patients who overeat. They might eat healthy foods, but they actually just eat too much foods. And typically it helps a patient who has a meal and 30 minutes later they're eating again because they're hungry. Those are the typical patients the gastric sleeve will help. The gastric bypass involves forming a little sleeve, so the patients eat exactly the same volume as a sleeve, 100 mils. They feel full up when they eat that small amount. But instead of removing the bottom part of the stomach, we create a shortcut between the top part of the stomach and the lower intestine, so that when they eat, the food goes into the stomach through the shortcut to the lower intestine, and it bypasses or misses out 200 centimeters of the digestive tract. Most patients would have somewhere in the region of 600 centimeters. So with the gastric bypass, the amount of calories that are absorbed are 33% less than it would be in a normal patient. So the gastric bypass makes us feel full up when we eat small amounts, decreases our hunger, and only absorb 2/3 of all the calories that we eat, including fats, sugars, calories. So the gastric bypass is best for patients who eat a lot but are not necessarily hungry all the time, but mainly for patients that make bad food choices, that eat foods that contain high fats, high sugars, high cholesterol. Those are the patients who would benefit more from a bypass because the absorption of those calories, sugars and fats is decreased by the bypass. Patients who are hungry and make bad food choices are better off with a SADI-S. SADI-S is a sleeve and a duodeno-ileal bypass rather than a gastric bypass. It still has the same effect, though it decreases calorie, fat and sugar absorption. Still makes you feel full up when you eat small amounts. And with the SADI-S, the sleeve is also performed, not just the bypass, so it dramatically decreases our hunger hormone ghrelin. So SADI-S treats all types of patients, whether they're hungry, whether they eat too much, whether they're addicted to bad types of food, or whether they make bad food choices.